Good afternoon, everybody. We'll get started here in 3 or 4 minutes as we're letting people move from the waiting room into the presentation. Just a quick note to say thank you to all of you for being part of this, our third lunch and learn. So hang tight just a couple of minutes. We'll be starting here in a moment. For those of you just joining us, thank you so much for being part of our third lunch and learn. We'll get started here in just a couple of minutes. Give people a minute or two just to transition between meetings. So hang tight. We'll get started here in a minute. All right, welcome everybody. We may have a couple more folks joining us, but um, it's slowed down enough that I think it's good for us to get started. This is the third in a four-part series, four-part lunch and learn series on Ohio's OARRS system. And really, in the first two sessions, we got a chance really to learn about the system and to hear about it from the Board of Pharmacy. Today, we are really fortunate to have Dr. Tessa Miracle, a faculty member from the Ohio State University College of Pharmacy with us. She has really deep experience. She's led Ohio SPIF-RX work, has worked at the community level really for many years, coalitions to supporting organizations, really an enormously broad and deep set of experiences. So we really are fortunate and really grateful to have her with us today. She's going to really lead us through some background and then also some exercises on how we can use county level OARRS data in our work and in our communities. So thank you again for being part of this and for devoting a lunch hour with us. And I think with that, we will turn it over to Dr. Miracle to have us to get us started.
Wonderful. Thank you very much. Thank you for joining me today. I'm so grateful to join you and talk about interpreting county level OARRS data. So today we are going to define some key terms related to Ohio's Automated Prescription Drug Reporting Program, OARRS. We're going to identify what data are recorded into OARRS, and we're going to identify how to access and interpret data that are available in OARRS. So I'm going to briefly go through, some background and talk about some key measures that are included within OARRS, but then I would love for us to have an active portion. So we have some discussions planned for you. You'll have the opportunity to access some OARRS data and tell us what you think about it. I want you to remember that as we do that, we're all learning together. So there are no real right answers. There's no real wrong answers. Sharing your expertise and your viewpoint is what's really valuable in this exercise. I'm also a very interactive speaker, so please feel free to jump in the chat if anything is unclear, if I'm talking too quickly, if you have any questions. So please feel free to interact. I also understand if you want to leave your webcams off. I know what it's like to try to attend one of these while you're eating. On prescription drug monitoring programs. This is a really nice graphic provided to us by the CDC. And when we look at this, we see a wonderful visualization of how the data flow through a typical prescription drug monitoring program. Now, as we know, for those of you who have been able to attend previous sessions, every state is required to have a prescription drug monitoring program, but each state was provided the flexibility and freedom to create and implement that database in a manner that made sense for the needs of their state. So at a very high level, we have pharmacies, either inputting or examining data from a PDMP, and we also have healthcare providers doing the same. As we look at data that is purely exported and for review, we have law enforcement, we have state health department, licensure boards, and insurance programs are able to look at those program data. In the state of Ohio, we also have an interactive data tool that we're able to use that I'm going to talk a little bit more about later on. Just to level set and make sure we're all thinking of prescription drug monitoring programs in the same manner. Prescription drug monitoring programs, often called PDMPs. I know in this work we kind of play acronym soup all the time, so I just want to make sure that I'm throwing it out there. They are electronic databases that are used to track controlled substance prescriptions in a state. These continue to be one of the most promising state-level interventions to improve prescribing practices, inform clinical practice, and protect patients who may be at risk. Evaluations of PDMPs have illustrated changes in prescribing behaviors, changes in number of providers used by individual patients, as well as decreasing treatment admissions for individuals with substance use disorder. Is PDMP, OARRS, Ohio's Automated Prescription Drug Reporting System. This was established in 2006, and OARRS collects information on all outpatient prescriptions for controlled substances and two non-controlled substances, gabapentin and naltrexone. And these are dispensed by Ohio licensed pharmacies and furnished by Ohio prescribers. As you remember, on our last webinar, our speaker did share that if a prescription is written and the individual does not pick up their prescription, those data are not included in OARRS. So these are only prescriptions that were prescribed and picked up by the patient. We have access to state-level statistics county level statistics, individual county level stats, as well as a map feature where we can look at some color coding and we can get a good idea of what is going on with our neighboring counties as well as ourselves. And so how can we access these data? So you can access both reports as well as an interactive data dashboard on the OARRS website. I'm going to talk today a little bit about how we can use both of those to help us out in our strategic planning. So as we look at state statistics that are available, we can see opioid doses dispensed to Ohio patients per year. We can look at the number of prescriptions. So we can look at doses and then prescriptions, which are two different indicators. We can also see Ohio patients receiving an opioid by year and doctor shoppers by year. And I want to call out those last two bullet points for a reason. So those last two bullet points are available in the reports that are furnished by our lovely friends at the Ohio Pharmacy Board. They are not data points that you're going to find necessarily within that interactive data dashboard. So I just wanted to call out that I'll show you where we can find those in our reports as well. Just so we're all working from the same definition. When we talk about someone who is labeled as a doctor shopper, this is a patient who has filled prescriptions from more than 5 prescribers at more than 5 pharmacies in 1 month. Another term that I want to make sure we are sharing and understanding the definition of is a morphine milligram equivalent. So morphine is really thought of as the standard for the treatment of moderate to severe pain, and it's used as the common reference point. This is really important for us because as the MME increases, the likelihood of an adverse reaction also increases. So that's why we hone in on this data point. And a morphine milligram equivalent is the amount of opioid prescription drugs converted to the common unit. It's the milligrams of morphine, just to level set between the different substances that are provided. If we look at the county level statistics, we can see the prescriptions per 100,000 residents, the doses per 100,000 residents. So remember, those are two different pieces of information for us. So I may have a traumatic injury that requires pain management for 7 days, and that's one prescription. I may have a more mild dental surgery that requires a prescription for 3 days. Those would both fall under a prescription. But if you wanted to know how much of the substance I was provided, you would need to look at doses. So if I'm getting 3 doses per day, that would be 21 versus 9. We also see our MME per 100,000 residents and our milligrams per 100,000 residents for gabapentin and buprenorphine. So let's quickly summarize before we have an opportunity to go into some breakout rooms and discuss a few pieces together. So we have access to the trends and rates in controlled substances prescribed by county and quarter. And we are also aware of the types of providers interacting with the system. So the types of providers, if you can remember from the state of Ohio, the veterinarians do not interact with Ohio's PDMP. So that's also a key indicator of who isn't at the table and who isn't there, especially as we're looking at strategic planning and how we're going to use these data to inform our work. These data are really valuable because they're aggregate and publicly available. I don't know about you, but data that I don't have to collect is data that I love to use because it's available, it's out there, and we can all access it at the same time. It allows us to identify the opportunity to identify trends in prescribing, and it is both reported quarterly and annually. So as we look at how we can use these data, I want us to take 4 minutes. I'm going to set a timer for a few minutes here. And I'd like us in our breakout rooms to discuss just at a very high level, your initial reaction. First, how do you feel these data fit into your either your organizations or your community organization's logic model, if you have one? Or on the other side, what potential pitfalls would you caution other organizations against when using these data initially? So where do you think it could get a little hairy for folks or confusing? So I'd like you to consider those 2 questions. I am going to paste them in the chat so you are able to access them in your breakout rooms. So I believe Matt is going to take us into our breakout rooms now.
Certainly, I'm going to push a button, and we're essentially just going to randomly assign folks to one of 4 breakout rooms. So when you see it'll be essentially a bar or a button that'll pop up on your screen. Just go ahead and click that, and you'll be transported right into the breakout room. We'll communicate with you through there. There's a way for you to signal us if you have questions at all, and then we'll send out a message when we're going to bring everybody back to the main session. So I'm going to go ahead real quick, and I'll open the rooms, and you'll start to see that coming across your screens. Has anyone gotten the notification yet that's come
No,
across?
no.
All right, it says Zoom is telling me that it's gone out, but the breakout rooms have 0 in them.
That's okay. You know what? Let's have a discussion together, guys. How does that sound? So let's address that first point together. It seems like breakout rooms don't want to be our friend today. And I think we are getting a message maybe from the Zoom overlords that they would prefer we have a discussion. I think we have the right amount of folks to work through together. So feel free to share either in the chat or to unmute yourselves. If you're, either your professional organization or maybe you're part of a community coalition, how do you feel these data fit into your logic model, or would they? Some folks might be typing into the chat, and I want to give you a couple moments. But I know when I worked on a community coalition, we used OARRS data to narrow down what substances we wanted to focus on as far as prescription drug misuse prevention. And we triangulated the data with community-based surveys, as well as some key informant interviews. So these data fit into our logic model sort of as a supporting piece, one that we knew that was collected and reported to us in a quarterly manner, as well as annually, just to target the number of prescriptions from the perspective of this is how many folks need education around medication safety. So I think some folks might still be typing, but we can move on to the next question. What potential pitfalls do you see for either your organization or another organization as far as using OARRS data in strategic planning or logic modeling? I want to give you guys some time to think about that, but I can tell you, based on my work with community organizations, both from community-based volunteers all the way up to community serving organizations, I think what is unique when we start looking at OARRS data or when we look at prescription drug misuse prevention, our goals tend to be a little different. So when we look at underage consumption of alcohol, we often want to get that number down to 0, right? Well, in this case, I don't know that that's an appropriate indicator because these medications are beneficial, they are helpful, and they exist for a reason. So rather than looking at OARRS data from the perspective of we want to reduce these prescriptions for down to 0, we have the opportunity to look and say, this is how many prescriptions exist in our county. This is how many opportunities we have to educate our community members on safe medication storage. This is how many opportunities we have to educate folks on safe medication disposal or other environmental strategies.
Yes, I love that you said that. I actually got invited to speak at a senior center in May, and they wanted me to talk for an hour on medication safety. And when I talk, I haven't done this in so long. I haven't done in-person things in so long. But I think one of the things that I hear the most often, especially speaking to seniors, is they get upset about the lack of access to these substances. Because of all the regulations that have been put on it too. So I think there's like a fine line in presenting this data, but also trying to meet them where they're at as well.
Exactly. And thank you, Katie, for sharing that. I'm with you. Being in the office and giving a presentation in real life, I feel like it's my first one again. I agree with you. I think we have to recognize that the goals are different, and maybe looking at these data can feel a little concerning to some folks. So making sure that we're engaging them in a way that is meaningful and respects their needs is really important, but also recognizing that medications are beneficial and they serve a great purpose. So our focus is really on safely prescribing them, safely storing them, and safely disposing them. And that's what feels different than maybe other substance misuse prevention efforts that we've engaged in. Great. And thank you for joining in. I do have some other thoughts for us. So I did briefly share with you, how we've used it in the past, but how would you use these data to support either prescriber or patient education? And feel free to put it in the chat or to unmute yourself.
Hi there, Susan Metzger from Pickaway Addiction Action Coalition. As far as like prescriber education, I always try to inform folks, do you have to go for that prescription? Or maybe if there is something over the counter that could maybe help with the symptoms that you're seeing to help reduce the numbers that could possibly be within your count.
Then for jumping in. Yes, I think, considering the needs of the individual patient is a wonderful choice within prescriber education. Great. We can also use data to identify or realign priorities. It kind of provides us a real-time snapshot of prescribing rates in our state or our county. We can use it to measure our prevention efforts. We can support prescriber behavior. So one of the wonderful campaigns I've seen it come out of a community coalition was thank you letters written to prescribers. Hey, thank you so much. The majority of our prescribers are using the OARRS in an appropriate manner. We just want to, reach out and say thank you for being part of the majority of prescribers who are engaging in best practices. So we don't necessarily have to look at it as, something to reduce, but also something to engage a different sector of our community. We can identify emerging trends, or we can track progress. So for this next bit, we are going to put folks into some breakout rooms. So I think our breakout rooms are working for us now. I'm putting a link in the chat for you to access. And in this scenario, what we're going to do is we are part of a newly formed community-focused organization. We can be a community coalition. We can be, maybe some folks at the health department who have come together, whatever your group. So you're going to be in a group of probably like 45 folks. What I want you to do is decide, we're a coalition or, whichever group you'd like to be. And we are in Franklin County. So we have united, we want to prevent prescription drug misuse and promote prescription medication safety strategies. We want to look at our educational campaigns on, proper medication storage and disposal. Maybe we want to do some environmental work around increasing access to disposal. And we are reviewing OARRS as part of our needs assessment. So I have a couple of scenarios for you guys that I'm going to have you engage in. So the first question we're going to take a look at is we're going to look at the gender comparison chart in OARRS in the interactive data dashboard. And we are going to look and see, is there a gender-based difference in prescription doses for Franklin County benzodiazepine prescriptions? And if so, what strategies would we suggest for an environmental approach to promoting medication safety? And then we also have a second question using that same gender comparison chart. And we want to know if there is a difference in gabapentin. So I'm going to add this link into the chat, and as well as our scenarios, and we are going to put you into breakout rooms. So first up, we have the link coming into the chat. And now we have 2 questions for you in this scenario. You should be receiving invitations to a breakout room. Is that correct?
Yep, I've just sent them out. So hopefully they are coming out this time.
You guys in just a few minutes.
We'll have everybody back in about 38 seconds.
I know why this group came back first. Look who's in this group. These are like the most awesome of awesomest here, right? These are the rock stars.
That's only because Christy came to Sandusky County on Monday.
I was so excited that you guys welcomed me there, man. I've been talking about you guys all week, how fabulous y'all are. So
That's awesome. Yeah, I thought it was a great day. So just
it has a great group of people. I wish every
actually
group could be like
to
that.
have Matt on this call too. We're doing this for our psychostimulant grant that Matt is managing for us. So
Oh,
Beautiful. Yes, and I know Christy had a great time. She had to tell me about it. She was like, it felt so good to be back in a room of passionate people. She was like, I forgot what that energy felt like. So great to have you here too.
all right, I think we've got everybody back.
So I want to hear from you. How did your conversations go? Feel free to unmute yourself or share in the chat. I was able to hop into a couple of rooms and I heard some of the nuanced discussion that I was hoping that you would have. So feel free to unmute, but I'd love to hear your thoughts on the data that you reviewed using the gender comparison chart to look at benzodiazepine prescriptions. What were some key points that your group discussed regarding these data?
Trying to understand why the numbers were so much larger for women than men, changes over time, and then wondering, is there things that could just explain this? Initially you might think like, oh, this seems unequal for some sort of, I don't know, reason that should be addressed, but maybe it's just unequal due to other factors. For instance, are women more likely than men to ask for help with anxiety or something like that? So we were kind of wondering, what is behind why these numbers are the way they are, and from that, you could get more specific then, I guess, with interventions.
Definitely. So I think there are two ways we could look at that, right? So we see that more women are receiving prescriptions. Some folks want to look at the root cause of that. And yes, it's always great to promote alternatives that allow people to access wellness in a different way that maybe prevents them from needing as much prescription. But it also gives us a wonderful audience to identify for education. So if we see that women are receiving a higher number of prescriptions, we may be able to target those prescribers and say, hey, we are recognizing there's this high number of prescriptions going out. Can you maybe educate folks on proper medication storage and disposal? And recognizing when we're creating those materials, maybe we need to have a focus with our material creators. So whether we're working with a graphic designer or we're working with a public health campaign creator, making sure that they are appropriate for the audience we're trying to target, correct? And thank you for sharing. What did we think about our use of the gender comparison chart for gabapentin? Did we find something similar or did we find something different?
They were higher. The prescription rates were a lot higher for women too.
Thank you, Joni. Yes, we saw higher prescriptions for women. Again, so just like we were discussing before, it doesn't necessarily mean we want to hit a point where we're saying they don't, we want to limit their access, but it's an opportunity for education on proper medication safety activities. I also want to share an example that we can review together. So let me just share my screen again. Great. So let's review an example together of how a coalition has used PDMP data. Now, this is an example provided to us by the Substance Abuse Mental Health Services Administration, SAMHSA, but we can see how they've used PDMP data to inform a community-based logic model. So in this logic model, we are part of a community coalition, and they have worked together to review PDMP data. So their goal is to decrease, opioid prescription medications used for a non-medical purpose. And I called out this logic model for a reason. Did you see the goal? It is not to decrease, access to medications that are beneficial. It's to decrease access for individuals who may misuse the medication. So I think that's an important goal for us to keep in mind, that these medications are beneficial, but they still need some safety messaging around them. When we look at how they used PDMP data, we can see their use in the short-term outcomes, the intermediate outcomes, and the long-term. So they saw the number of prescribers that reported understanding how to use PDMP data to screen for patients who may be misusing prescription medications. That's another way PDMP data can be used, is to look at the prescriber and target the prescriber for educational campaigns. They also looked at, now this is a little bit different than what we have access to, but they looked at the percent of prescribers trained in PDMP use who have changed their behaviors as far as use of the PDMP after a workshop. So this particular example organization went a step beyond just looking at the PDMP data, but saw that, oh gosh, our prescribers need help using this PDMP. Let's partner, create a training, and then see if that changes their use of the PDMP as a tool. So I think this is a good example of how PDMP data can be used in a manner that isn't directly targeting the prescription, because we want to recognize that prescriptions are provided based on need of the patient, and we don't want to deny the need of the patient. So time for us to do a little bit of group discussion. So we've gone into a breakout already, and I know Matt, I said let's do a breakout here, but I'm going to switch it up and let's stay together as a group. So after we looked at this logic model, do you feel that there are any efforts in your community or in your professional organization that the PDMP data that we took a look at today could support your work? So especially now that we have an example that is a little bit different than what we've done before, and we've had a chance to look at the data, are there any efforts that you're working on that you feel PDMP data could support? You're welcome to unmute or put your examples in the chat.
Tessa, I'm thinking as far as just like with the inputs, how we could use this data. We're in Pickaway County, and I don't, I doubt many people just like off the street or know about like how much is being prescribed and used, and just collaboration with the local hospitals that we have in here. There again, some safe prescribing, some safe disposal efforts, when you're through with that type of medication, and maybe spreading the word about what it's like within your county, throughout your coalition, or through, different types of focus groups that you may be working with, to say, hey, in comparison to the state, this is where we sit. And, just trying to get some focused learning groups to say like, okay, this is good, this is bad, or what can we do? Let them take ownership of how a change may be needed.
You're right. Knowledge is power. And I think, particularly as we look at PDMP data and OARRS data in the state of Ohio, I don't know if your experience is similar to mine, but I feel like, as a community member, I often felt like those data were kind of over here. And that was for hospitalists to use. And that was for some other policy folks to use. And it wasn't necessarily for me to use. Well, now that we have this wonderful interactive dashboard, the data are in your hands and they're there for you to use, and they exist for a reason. So I completely agree with you. Educating our stakeholders on what data are available and how we stack up to our neighboring counties are great ways to use these data. Anybody else want to share? I don't want to cut anybody off. Great. Now, I want to remind you, at any point, feel free to jump in. Don't feel like you have to wait on me to pause for you to share your thoughts. I had left room for us to discuss and prime ourselves for next time. So next time, we are lucky enough to have Christy Valentini join us to talk a little bit more about using OARRS data in strategic planning, but to prime us for that presentation, and just really to get us thinking about what community-based efforts we have going on, and look at a couple of examples, and also think about who specifically needs to know about OARRS. I want to just ask a couple questions of you. So what are examples of community-based efforts that you feel would be enhanced by using OARRS data? So are there any particular community-based efforts that you have? So is there an educational campaign in your community? Is there a disposal campaign available? Or is there a community coalition you're working with?
I'll jump in in regards to that. Community-based, so our coalition has a branded educational program, prescription drugs through Prevention Action Alliance here in Ohio, Columbus area, that we've actually had our coalition logo emblem be embedded onto some of their information. We've been giving it out at health fairs just to let folks know of signs that you may be able to see within friends or loved ones within the family. We're also active in distributing the doTERRA bags to help dispose of these medications, to make sure they don't get into the wrong hands, and then also promoting the upcoming Drug Take Back Day at the end of April here. So we're trying to get the word out through social campaigning, Facebook, local newspaper, and things like that.
Really great way to use these data. I've included some examples as well, but it's always great to hear from a community coalition and exactly what you're doing. One way that I have been able to use OARRS data is pre-service prescriber training. So we are very university and college rich in the state of Ohio. We are very fortunate. So odds are your coalition is probably within 30 minutes of a university. You know, our prescribers are able to access an OARRS training that is available based on specialty that will look like the dashboard they're going to access once they're out in the field. And gosh, what a wonderful collaboration to work with our local university to make sure that that's available. Also recognizing that, you know, this is kind of a dual combo hit. So we have the OARRS data that are available so we can see how many prescriptions are in our county, but we also understand the OARRS platform. So I think that's a great example of a community-based initiative. You touched on medication safety campaigns, you know, prescriber education and prescriber engagement. I always say, you know, thank your prescribers for using this efficiently. I kind of liken it to the we are the majority work we do with youth, where we know the majority of prescribers are prescribing appropriately. They have the health and safety of their patient in mind. And it's just always a good practice to, you know, thank them for, you know, being a partner in prevention in that matter. Promoting safe prescribing practices, and then safe medication and disposal, as you mentioned. When we look at who ought to know about this at the local level, I think community coalitions are wonderful groups to work with. Schools, it's always good for them to be aware of data that are going on in the state, because our children often feel the impact of whatever our adults are going through. Pre-service healthcare providers and educational institutions, child protective services, having their awareness of proper medication and storage and disposal opportunities within your county are immensely helpful to those organizations, particularly around foster care. And then veterinary service providers. So if we can remember from our previous presentation, our veterinarians don't have to use OARRS, but that doesn't mean they don't care about medication safety. So providing access or sharing information, not only about the current OARRS data, but also resources are very helpful for this coalition, or for this particular group. So I'd love to hear from you about how you plan to use these data, and you can feel free to, you know, put those in the chat or unmute yourself. And then the last thing I have for you today is a couple things you can do and a couple resources for you. So I'd love to hear from you what questions you have regarding these data, and what do you want to do with them? Sometimes after receiving something new like this, it can take us a little bit. So I hope that you're able to reflect on the information that was provided. And I hope you find meaningful use of these data. And I want to remind you that I'm always available for questions. I know we have a lovely team of folks who have pulled together this presentation for you, and they're always available for you as well. What some steps to, you know, empower you? You can review your community data. You can update your strategic plan, are things you can do with these data. If you're looking for specific action steps, you can look at, you know, workflow optimization opportunities. So in the state of Ohio, there was a point in time where OARRS was not integrated into electronic health records, and there are always more workflow optimization opportunities. We can promote safe medication storage. We can promote disposal. We can thank our providers, and we can always take a nuanced look at these data and see how we can be supportive. The other piece I want to let you guys know exists. So we do have an interactive map of permanent prescription disposal locations available in the state. OhioRxDisposal.com. You enter your address and all the pins pop up around you. We now also have restarted our mailing of disposal bags to individual folks. So if you need, I know that grant funding kind of ebbs and flows. So if you find yourself in a point where you would like to provide at-home medication disposal to community members, have them request a disposal pouch from OhioRxDisposal.com, and we will mail it to their home. So that is one resource that is available to you as a coalition at no cost. That's a state level resource.
And in the chat box too, Jim Posey mentioned that even if they don't have something right now, they definitely are going to use the OARRS data and the OARRS resources in the future with their communities.
Great news. Thank you, Jim. So I have put my contact information on the screen. I'll drop my email address in the chat, but I wanted to leave this time for you to ask questions or any discussion that you felt was left unresolved from earlier today. If there are no comments or concerns, I invite you to enjoy the rest of your afternoon. I appreciate your attention and your time that you spent with me today. And I thank you again for your efforts in Ohio.
Thanks so much to all of you for being part of this. This is our third Lunch and Learn. We did record it, so we'll be able to get that out as well. Please do reach out. We're all here, and we're here to support your work, to support your communities. So thanks so much, everybody.
Tessa, can I ask you a quick question about the RX disposal? When you put your zip code in, how do you get on there? Sandusky County has several permanent take back locations, but when I put in our zip code, nothing came up.
Oh, no. Is there, so if you have, do you have a list of those disposal locations?
Yes.
Can you